All right, so welcome to this evening's event on racial equity, vaccination, and medical research. A lot of you guys know One Day Sooner already, but perhaps not all of you, I know, because tonight the New York chapter of the Harvard Chan School of Public Health Alumni chapter is co-sponsoring this event with us, so hopefully there's some folks from that organization that are joining us perhaps for the first time. So One Day Sooner was founded in March and April, to advocate for human challenge trial volunteers. We want to advocate to get a vaccine more quickly, to reduce some of the devastation that we are seeing once again right now. And we're also concerned with the whole sort of vaccine development process and distribution process. We're very concerned with medical ethics. That's really at the core of what we do, as concerned with challenge trials, as well as with the entire sort of vaccine development process. And so part of that, of course, is thinking about equity, thinking about race and racism, long history of race and racism in American society, in medical research. And we want to open these conversations and continue having these discussions as an organization, doing this work and exploring these issues in challenge trials, as well as issues in vaccination more broadly. Obviously, the longer the pandemic goes on, the more and more we hear about the disproportionate impacts of the disease. We started hearing that in more specifically in April and May, and those disparities haven't dissipated. So obviously they need to be a part of the conversation, not just around developing a vaccine. Pfizer obviously came out with big news earlier this week, but also with distributing that vaccine, and of course potentially developing second or even third generation vaccines that might have fewer of the challenges that some of these mRNA ones do. And a lot of us have also been hearing stories about diversity and participation in challenge trials. That's sort of one of the waves in the news cycle. A month or two ago was focusing on that. And so again, as an organization concerned with medical research, concerned with ethics and all of that, that's a big part of what we're thinking about. And so we wanted to hold this panel and hold this conversation to start to engage some experts on those issues. Really with the belief that inclusion is important, but that there's much deeper issues to explore, both in Western vaccine development, but also in medical research more broadly. So this conversation will actually bring together two scholars in the United States and one who is in Canada and also concerned with global issues, studies global issues. So we'll be looking on a couple of different scales at some of these issues in a couple of different contexts. And so I will introduce them more specifically in just a second, and then I'll let each of them talk for about 10 minutes before we go into the Q&A. But what I want to highlight about what they've all published on COVID-19 already, and I'm sure have continued to think about these issues, since their articles came out. But they're all really engaged with questions of not just what's going on right now, but what will be going on in the future. And that means, I think, both the immediate future of, we know this pandemic is going to keep going for a while still, even once we have this vaccine, but I think they're all thinking in much longer terms too, thinking about, larger issues in health disparities and global equity. And so, the question I've posed to them is about, what we can do to fight for equity now, but then also what needs to happen long term, thinking not just in terms of a year or a few years, but decades, because this work is going to go on for a long time. There's a lot of damage done in the United States and around the world, and we want to be a part of those solutions in every way that we can. So I'll read quick bios of everyone, and I'll give you the titles of some of the articles that they've published recently as well. And then again, I'll give them each a few minutes to talk, 10 minutes to talk before we go into that Q&A. So Dr. Deidre Cruz, who was just promoted to full professor today, is at Johns Hopkins. And she is she's a full professor of medicine in the Division of Nephrology at Johns Hopkins. And Associate Vice Chair for Diversity and Inclusion in the Department of Medicine. She's also the Associate Director or Assistant Director of the Center for Health Equity. And her research has examined the contribution of social determinants of health, including poverty and access to healthful foods, to disparities in kidney disease. And she recently published with Dr. Lisa Cooper an article titled COVID-19, Racism and the Pursuit of Healthcare and Research Worthy of Trust. Dr. S. Michelle Ogunwole is a health disparities researcher, social epidemiologist, and general internal medicine physician, specializing in the care of women with chronic medical conditions. And she has advanced training in quality improvement and patient safety science. And she recently published with Lisa Cooper and one other author whose name I don't have in front of me, an article titled Historical Insights on Coronavirus Disease 2019, the 1918 Influenza Pandemic and Racial Disparities, Illuminating a Path Forward. And finally, Dr. Ubaka Ogbogu is at the University of Alberta. He's an associate professor in the faculties of law and pharmacy and pharmaceutical sciences. He's the Katz Research Fellow in Health Law and Science Policy. He's a Pierre Elliott Trudeau Foundation Fellow and a recipient of the Confederation of Alberta Faculties Association Distinguished Academic Early Career Award. He's a nationally recognized expert in the fields of health law, public health law and policy, law and science, and bioethics. And he recently published work on bioethics and practical justice in the post-COVID-19 era. So we're doing a lot of time traveling this evening and some geographic traveling too, since I know that two of you work in Baltimore, and then Ubaka is studying around the world. All right, so Dr. Cruz, you can go ahead. All right, you can unmute yourself.
Okay, thank you. I was trapped there for a moment. So good evening, everyone, and thanks for that wonderful introduction. I'm really happy to be with you all tonight. What I thought I would do, because I'm joined tonight by scholars who will have, I think, much more specific expertise that they can share around pandemics and maybe in COVID-19 in specific. I'll tell you a little bit about the type of work that I do and talk a bit about the where I see the challenges with regard to the mitigation efforts, in particular around COVID-19. And so as was said, I'm a kidney physician at Hopkins, and my research work is focused on disparities in both kidney disease as well as hypertension. And I, more broadly do this work that's in addressing social determinants of kidney disease, including work around access to healthy foods and the role that limited access plays in the disparities that we see in kidney disease. So in this time, I'll use kidney disease as an example. I think it's a chronic condition that has come into light during this pandemic, in that people with who are known to have kidney failure or advanced chronic kidney disease have been at high risk of having very poor outcomes from COVID-19. Many of you may be aware that in those first few cases that were documented in Seattle, that they were actually I think it was the first or the second person to die in the United States was a dialysis patient, a kidney dialysis patient. And so the dialysis setting is a sort of a convalescent setting, if you will, where people are, a congregant setting, not convalescent, but a congregant setting where people are, in a room together 3 times a week for around 4 hours each time. And so there was lots of concern around the impact that COVID-19 would have on those people, as well as you may have heard that chronic kidney disease, even earlier stage chronic kidney disease, is a risk factor for poor outcomes. And in the United States, more than 30 million people have chronic kidney disease. And so when you've heard talk of comorbid conditions that raise the risk of death from COVID, certainly people with chronic kidney disease are an example of that. In addition to that, sort of adding on to that, people who develop COVID infection also, sort of if they're sick enough to be hospitalized, for example, they may develop acute kidney injury, which sort of amplifies these problems. When it comes to, I think, the topic that we're most focused on tonight, it's important to note that chronic kidney disease disproportionately affects Black, Indigenous, and other people of color. And it also is more of a burden among people with low incomes as well. And so we have been seeing compounding of some of the known disparities that already existed in chronic kidney disease. We're seeing that many of those same populations then being impacted by the pandemic. My work, as I mentioned, and much of what we wrote about in the piece that Dr. Cooper and I authored was really focused on thinking about what we need to be doing as far as thinking about the impact that not just the infection rates and morbidity and mortality from the infection, but also the impacts of the mitigation efforts. Not only, sort of thinking through those things, but thinking then forward about how are we going to instill and in many cases newly develop trust in populations that we know we're going to want to engage in for the dissemination of an available vaccine, as well as, as we're going to be talking about tonight, we're going to want many of these same individuals who have had who've had negative experiences in many cases with the healthcare system, and there are many cases of what I refer to as well-earned distrust in the system. What we talk about in our piece is, how can we go about building that sort of trust? And we try to call for not just work that can be done at that kind of individual level, people like me who are clinicians who are taking care of patients who are coming in either for their regular primary care or also coming in for COVID infection, and the relationships that we might be able to build with them, but also thinking more at the level of health systems and public health systems, and what we are doing there to build and restore trust, again, in places where the lack of trust has been often well earned. And of course, we are dealing, as we're thinking about the trust that we are going to need to have in place in order to have broad participation in vaccine trials, as well as broad uptake of a vaccine once available. We're also dealing with other threats to trust among many of these same marginalized populations when we think about the recent high-profile acts of racism that we have all witnessed really through these video recordings, and the impact that has had on many of these same communities that we have concerns about as far as a vaccine. And so we really, and I'm excited about the work that you all are doing at One Day Sooner. We really have to double down and think carefully about how we're going to be able to restore that trust. And so I think I'll stop there, and I look forward to the conversation.
Michelle, can you share are you good?
Yes.
Okay.
I'm going to share my screen. Thanks. Can everyone see my screen? I'm hoping. So thank you so much for having me. I agree. This is such an important discussion, and it definitely feels even more timely, I think, with this news that Pfizer recently released about its vaccine efficacy. And I think for a lot of people, that kind of news makes it feel like we can have a little bit of hope, and we can start to feel like there might be some light at the end of the tunnel. But it certainly makes this conversation, I think, even more important as we think about next steps after that. And so thanks again for having me here to just continue to have this discussion. As you noted, I'm an internal medicine physician and a health disparities researcher. My research really actually focuses on racial disparities in maternal health outcomes. And as an internal medicine physician, I really think about the role of chronic disease in pregnancy outcomes. And as a social epidemiologist, I think of the social risk factors that Dr. Cruz talked about and how that might also impact pregnancy outcomes. And so I just have a few slides that I was going to share just to walk through this. And it's interesting. I was kind of reflecting on this unique moment in history and having a novel infectious disease and what that really means for all of us as researchers, is that we've really been learning together. So I think at the beginning of this, there were really no experts in COVID-19 disparities, but as we've continued this journey, I think what we've all learned, the people who do the work of health disparities, what we know is that for the most part, the drivers and root causes of disparities are unfortunately really similar. And that's kind of where I wanted to start. You know, I'm just showing kind of a picture. This is from the Kaiser Foundation about the social and economic factors that really drive health outcomes. And we see so many things that Dr. Cruz talked about: economic stability, neighborhood and physical environment, education, food, community and social context, and then the healthcare system. And I brought this up because this is a slide from Dr. Monica Hooper, where she showed the kind of similar drivers, I think, of COVID-19 disparities. And I just wanted to highlight, even though it's a different disease, the same drivers exist. And in a lot of ways, I could take COVID-19 out and put chronic kidney disease disparities. I could put maternal health disparities, and especially other infectious disease disparities, and it would still hold true. So I really wanted to highlight that piece, and how I think we've all kind of had to learn to really think about our work in our other topics and think about how it relates to COVID-19. And so I was going to talk a little bit about this piece that we wrote, Historical Insights on Coronavirus 2019. And really the context of this was we were looking at the effect of the 1918 influenza pandemic on Black Americans specifically. And we really wanted to think about what we could learn. We chose 1918 because it felt most aligned in terms of scope and impact in terms of a pandemic. And then the other reason was, at the time, they did not have a vaccine for influenza. And so it felt like we were in a really similar situation. And what we know is that we can't really look at the past to offer predictions, because history never repeats itself exactly, but we do have this opportunity to really ground our current and future strategies in historical context. And that's something I think that we have to continue to do even as we move forward in our discussion today. And so the hope is that we can learn from the things that went wrong and those things that went right. And I say that we have the added benefit of a century's worth of scientific advancement kind of as we move forward. And one of the things that I'll highlight here in this table, we actually looked at the historical context at different phases of the pandemic and thought about what we could really learn in terms of what happened in the past and what the present and future opportunities are. And I'm just going to focus a little bit on this last piece, which is about communities of color leading and persevering and innovating. And we thought, like, we saw this a lot in the 1918 influenza pandemic for Black Americans, how they really corralled in terms of their community to save themselves, to lift themselves up, how they had to fight disinformation by using trusted sources within their community. And we thought that the real lesson from that was that we should also realize that there's a lot to learn from communities as leaders, and we should give them the opportunity to really actively participate in agenda setting, research, and policy initiatives. And this includes vaccines, obviously. And this other piece is really a part of something that we call a critical race theory, which talks a lot about this idea that we should center at the margins, which means that the people who are traditionally kind of left out of these decisions that may be at the margins, that we really should include them and center their thoughts and their perspectives as we move forward. And that's one of the ways that we kind of create the right type of research questions and the research agenda, and that disseminates through every phase of kind of our research and implementation, and eventually hopefully uptake of our interventions. And I think people may have seen this data before, but I was looking at this data from the Pew Research Center about what people were saying about vaccines, and this was looking at May from September, and we'd seen that, this is the percent of US adults who say they would definitely probably get a vaccine, and that number had just declined, and that was true across gender, race, ethnicity, age, and education. And so now that this, it feels like this vaccine could potentially really be close, how are we going to deal with that? And so, like a good social epidemiologist, I have kind of a conceptual model which we use to really think about how to orient the interventions that we're planning. The one that I'm showing here is called the health beliefs model, and it's really a model that helps us to think about the things that drive individual behavior. And so in this case, if we're thinking about vaccine uptake, what are the things that actually are going to drive that? This model really thinks about the fact that people have four kind of big things. They think about their perceived susceptibility to a disease, like, am I even likely to get this? And then they think about their perceived severity of disease. So if I get it, does it even matter? Is it really going to affect my life? What are the perceived benefits of this preventative action? So let's say this is a vaccine. Is it really going to help me avoid this disease that could potentially be severe? What are the perceived barriers to me actually getting that preventative action? And then what's the perceived self-efficacy? So do I believe that I'm able to actually do this and get this kind of preventable action, which in this case, I'm using the model, obviously, of a vaccine. And going back to this idea of history, I think that we have a lot of examples with the influenza vaccine where we have disparities among racial and ethnic minorities, with Black populations having a lower percentage of being vaccinated for the influenza virus. And the kind of reasons behind that still break down into these kind of individual beliefs, along with some of these modifying factors, right? But the reason why the perceived barriers are really highlighted in red is because this tends to be really the biggest thing, and it's been demonstrated to be really the single most powerful predictor of health behavior. And so we've seen this in the influenza virus. So those perceived barriers could be structural in terms of how do I actually access the vaccine, or they could be kind of individuals, right? Individual beliefs that are propagated through the community, right? Like, we shouldn't get influenza because it'll make you get the flu, like those kinds of things. And so that's kind of the framework that I bring to this discussion on vaccines and how we think about equity, and really the levers that I think we're going to have to pull. And going back to that idea of community, how we can really center the community to help us address some of the individual beliefs and the actions that are necessary. So I'll stop there.
Thank you so much. All right, Ubaka Ogbogu, take it away.
Thanks. Thanks, Dr. Cruz and Dr. Ogunwole. That's it's a tough act to follow. Yesterday, I was in a similar panel back here in Canada, talking about the COVID-19 vaccine and vaccination in general. And at the end of the formal session, we went into breakout rooms. And in the breakout rooms, one of the participants, a Black woman, asked me if she should take the vaccine when it comes out. I'm, of course, paraphrasing her question. It was a much more loaded question. And it really threw me for a loop, because embedded in our question was what Dr. Cruz was talking about, ideas of trust. She obviously had seen information about all kinds of disparities in terms of impact on members of the Black community in Canada and elsewhere in the world, but also information about the trials and how they're not inclusive. And she just didn't know if she should be taking the vaccine when it comes out. And so, I didn't quite know how to answer, because she'll ask a very direct question: should I take it when it comes out? And I kind of fudged and hedged. And I said, look, you have, ideas of risk from the vaccine and the notion of risk from the disease itself. This is a personal decision you have to make. But what struck me at the end of all of that, and I sat after the whole session ended, and as I was reflecting on it, was how in that session, she waited and sought me out. I was the only Black panelist. She sought me out, waited very patiently, just to ask that question. I think that anecdote sort of highlights how race is central. Race and racial inequity is central to conversations we have about not just COVID or the COVID vaccine, but public health and science and technology in general. I study policymaking in the realm of health and science and technology. And without a doubt, I would say that if you think about the world as a place that is bigger than Western nations, the single biggest issue when it comes to policy making and how we go about science and technology is racial inequity and issues of lack of fairness and inequities that exist in terms of the benefits and burdens of technology and of disease. And so that's what I'm going to focus my comments on. I'm going to talk about the global context mainly because I think those of you in the US will have some appreciation of the fact that when it comes to members of the Black community, members of the Indigenous community, and other persons of color, there is just a great deal of inequity that exists compared to Caucasian populations with respect to social determinants of health, the distribution of disease, and the benefits and burdens of things like vaccines and technology in general. In Canada, this is an issue that as a nation, we have failed to confront in any way that makes any sense. But I don't want to talk about Canada because I think the issues are very similar to the US. In Canada, we don't even collect race-based data. So we don't even know the extent to which this affects communities of color. And even though people have sort of pointed out in the context of the COVID-19 vaccine, COVID-19 as a disease in Canada, we still don't have national data. We have still not collecting that data. And so when the vaccine does come, there's going to be many issues with how it's distributed because we know it's impacting communities of color disproportionately, but we just haven't measured that impact, and we don't know how impactful it's been on those communities. But I want to take this beyond, to another dimension of race along global lines. You can talk about race within nations, but racial inequity along global lines, I think, is actually the bigger issue because there are nations around the world that will not benefit from any of this and will bear most of the burden of this. And if you think about distribution of disease and distribution of the things that address disease, these nations are so far behind. And you can, in fact, think of these nations as divided along racial lines. My focus in the research that I do is on African nations. I'm doing a project right now where I'm trying to catalog the extent of biotechnology research and development in the African continent. Who's doing what are they doing? Is there any health biotechnology going on? What do they have in place, both in terms of research and development and infrastructure for that, as well as policies to provide for the regulation and integration of these technologies into their economies. And it's still at the very preliminary stage. But what you'll find is that compared to the global north, there really isn't much in places like Africa. And so I want to talk about that racial inequity that exists among nations. Vaccine science and technology and biotechnology in general, from the bench research stage, so if you're thinking from basic research through to manufacturing, approval, the type of products we make, clinical adoption, all of that, that is essentially a very inequitable affair. The choices that scientists make about what kind of disease to focus on, about technology design, how they design the products, product delivery, who buys it, who makes it available to their citizens, all of that stuff is just a basket of inequity. If I had 2 hours, I could give you numerous examples of this. The associated regulatory frameworks that we use to think about how we do the research, how we distribute risk in research, how we distribute the burdens of research, how we regulate research, all of that is also pretty much defined by Western nations. So there's kind of policy hegemony or dominance that doesn't allow space for bringing in other ideas and shuts out the rest of the world in essence. That inequity, there's numerous examples of it I can give. And so maybe that's what I'll do is just reel off examples for you. And then we can talk about them during the Q&A. So with COVID-19 vaccines, for example, they're all produced in the global north, all of them. None of them is being developed anywhere in the global south. And as you know, the first stocks of the Pfizer vaccine and to some extent the Moderna vaccine have already been bought up by Western nations. There's not even enough to go around within these nations. And so before it gets to any nations in the global south, it might never get to them. They have to find other ways to actually deal with COVID-19 as a disease. It's not going to be through vaccines, at least not in the short term. This is not the first time we're seeing this. During the H1N1 pandemic, wealthier countries had expeditious access to vaccines. Poorer countries had to await donations to be distributed by the World Health Organization. We learned nothing from that. So we're back there again. With Ebola, a vaccine was developed in Canada. It was developed with investment from the government, and it was developed by Canadian researchers working in government-run institutions. And because there was no private sector investment in the product, there was no financial incentive to develop it because it's a disease that affects low-income countries. It's a disease that came up in sub-Saharan Africa. So industry didn't invest in it. And that's why the Ebola vaccine never actually took off. Because it was a disease of poorer nations and it never made it to the West, nobody was interested in investing in it. And when they eventually did produce some of it, it was used mainly for Western workers, health workers from Western countries who had gone into Africa to help out. H5N1. So thinking about burdens of the research, Indonesia stopped sharing its samples of the disease with the WHO due to a concern that the samples that they provided freely to develop to researchers were being used to develop vaccines for wealthy countries. So the burden of the research, Indonesians are donating their samples, and companies in the West are developing products, and those products were going to be used in the West and not in Indonesia. And then if you sort of extend that, because we're talking about medical research as well, if you extrapolate from that, there was an article in the journal Cell that came out, I believe it was a year ago, 2 years ago, that shows that majority of studies of genetic association of disease, and genetics is very important, as you know, that it's very important to vaccine development. Majority of the studies of genetic association of disease occur in populations of European ancestry and produces results that have utility only for European and Western populations. So much of the research that's going on in the field of vaccine development and in biotechnology in general will not benefit about 3/4 of the world. It will not make it to many low-income countries and countries where, that are represented largely along racial lines. And then the policies that fit into that as well, how we sort of organize research, how we organize who benefits from research, the patenting system, how we regulate research, how we move resources back and forth, how we decide who buys what, how we price it. All of that stuff is decided by countries that are economically rich and powerful, and those policies don't translate well to developing countries. And just another quick example from COVID-19 as well. The Pfizer vaccine, minus 80 degrees storage. For the longest time, people have been talking about inclusive design and about making products that can actually be used in low resource settings. You're not going to use, even if it was available to these countries, you're not going to see them because they don't have the infrastructure for 80 degrees storage. Even in my country, Canada, indigenous communities live in places where there's no good healthcare and there's no facilities for providing healthcare. They're going to have to sort of travel with those vaccines to them if they're going to get to those populations because there's nowhere to store it. So even within nations, these disparities exist, and it's a story not just of disparities along income, but also along the lines of race, and largely around the lines of race. So all of that is to say that these things are not new. We've seen examples before, but we always react when disease comes and there's an emergency and there's trouble, and we start talking about these issues again. But in peace times, everyone loses sight of it. And I fear that we're going to get back there. After COVID-19 is resolved, there'll be no attempt to sort of turn these things around and think deeply about issues of justice and about how we can actually make the world a truly global community when it comes to how we distribute the benefits and burdens of research, including vaccines. So I'll stop there.
Thank you all so much. So folks are more than welcome to either raise your hand or put questions in the chat box. I'm going to take the first, squeeze my moderator privilege and take the first question. So I'm particularly curious if Deidre and Michelle have responses to Ubaka's comments. I think there's a lot of similarities, and as an organization, we're increasingly moving towards thinking about global equity, but obviously we're largely based in the United States. So I'm very interested to hear if you guys, what kind of connections you're seeing and how those two conversations can be put in dialogue in a useful way.
Yeah, I definitely was struck by it. I have collaborated a bit, with some colleagues in Canada, and have been struck by how, information is not disaggregated, as you noted. So it was interesting to hear you talk about that, about how, there's really no tracking there in it. And then thinking about, I think in particular, low and middle income countries across the globe where not being even invited to the conversation that we're having here tonight and others are having about what it's going to look like in terms of dissemination. There's, I should have said this at the beginning, and that at Johns Hopkins, as was stated, I'm one of the associate directors of our Center for Health Equity, and we kind of have this sort of global to local, local to global sort of focus where we do have some partners, particularly in West Africa, and are conducting some studies and so forth there. I think not specifically on COVID, but more on our sort of broader body of health equity research. And so I think that there is going to be, and there should be, more opportunity for us to kind of learn from each other, and not just necessarily in a unidirectional way where, we're saying here that this is what's working here in the United States, and let's sort of translate that to others, but that there should be this sort of bi-directional exchange. I think that the socio-political pressures are, unique to every setting. And I think any sort of work that's being done to try to support for example, the dissemination of vaccines particularly to low and middle income countries will definitely have to be sensitive to and responsive to to those sort of pressures, and how priorities are set differently in different settings as well. And so yeah, I don't have an answer, but I would say I definitely think it's an area that we will have to do much work on.
Yeah, I echo that. I think it's challenging because you brought up this idea of justice, and obviously that's something that we think about in terms of health equity and health disparities. I think about the United States context and some of the things that we even ask of our institutions in terms of justice. We talk about our hospitals being anchor institutions, which means that they have a responsibility in the communities they serve to really help make sure that the resources that are needed to achieve equity happen. And that language, I think, is not really applied globally, in the sense that what is our responsibility as partners and good citizens to other countries, right? As these, like you said, wealthier economies, like what is our responsibility? I mean, certainly we have organizations that have done that work, but I think, like, you mentioned, Rebecca, that what happens when when this like moment in time is kind of magnifying everything. Everything feels so urgent, and when the spotlight's off, like what's actually going to happen? I think those are the questions that we have to ask ourselves. And then maybe this is something else I was just thinking about too. We talk a lot about, or this idea that I said about centering at the margins and bringing people into these discussions. There are colleagues that I work with at Johns Hopkins in the Global Health Department who actually have this lived experience of having been what I guess would be equivalent to community health workers that give out vaccinations in their home countries. And it's really fascinating to me, the barriers that they talk about, which are wildly different, as you spoke of, than even the things that we're talking about. So it's still social determinants of health, but it's in a very different way. And so I think, again, the idea that, like, how are we bringing those people who are on the ground, it's like these bigger things, like we don't have the capacity to have a negative 80-degree fridge. Great. But there's some stuff that's happening on the ground. Like there's no way that we're actually able to deliver all these things to all of these different remote locations and it actually be tracked accurately. So what are we going to do about those things? Even if we had the resources, how do we start to bring those people who are actually on the ground to the discussion? And like I said, I don't, these are just thoughts, right? And trying to think about what Deidre said, which is like this kind of, also this kind of global to local, like what can we learn and what can we teach, I guess, in that way. So thinking about the things that have worked here in the US in terms of advancing equity, I think is bringing other people to the table who really understand the problem. And then I think we also could learn about our responsibility in helping other nations. But
thank you. All right, Zachariah has a question.
This, I think, for me, it goes to Obaka. I like what you mentioned that genetics, I think, plays a huge role in vaccine development. And obviously, if not all the virus races, for a matter of argument, if they're not all considered during the process of vaccine development, it becomes very, I guess, unlikely that the vaccine would be as effective in all these races that were not part of the trial phase. So going forward from that point, I don't know, maybe from the point of policy or from your experience, what would you suggest as a solution? What would need to be done to address this particular problem? Because I think you also mentioned that all the vaccines that are being developed, none of them are being developed in the global south, which ultimately with poor infrastructure, poor medical services, and the list of problems can go on. But these people also need the vaccine. One way or another, they need the vaccine, because if not everyone is vaccinated, then we'll just be doing rounds and rounds, because the virus is going to start spreading all over again, and then we just keep on going in circles. So maybe to address the issue, what would you suggest as a solution, or what do you suggest as a need that should be taken in terms of action?
Thanks, that's a great question. I'm a lawyer, I'm very good with identifying problems and less so with identifying solutions, but I'll give it a shot. So I think the one big difference about vaccines we're seeing now and technology behind them and the vaccines, say vaccines for smallpox and vaccines we had in the past, is these vaccines they're sort of a different ball game. They rely on technology that's somewhat different from, attenuated viruses then injected into people to create immunity. And there was a ton of effort back then, with vaccines for polio, with smallpox, to make it global. And that's very commendable work, and you can look back in that history and say, there's hope. With these new vaccines that are based on genetics largely, and don't really follow sort of that old model of attenuated virus. And I think many of the ones in development right now cannot track that. I think you need the same kind of strategy that we used in the past, but to modify it in a way that's that will help with the development of these kinds of vaccines that we have now. So how much you go about that? I think the first thing is to build our thinking around how we address disease and the solutions to disease, to take it outside of sort of national boundaries. Disease is no longer national. Disease is now global. Even if the United States buys up all the stocks, once air travel starts up again, we're going to be back to where we started, right? So the first thing is to start thinking global when it comes to research and development, and start thinking global when it comes to policies around that. That to me is really the only solution. Unless we start thinking global, then countries won't want to finance global. They won't want to provide support for global. They won't want to think about global policies, right? So they need to sort of break out of this sort of national mode of thinking when it comes to public health and global health and diseases in particular, and start thinking global. What will that do? So I can, in the paper that I shared with Mabel, I talk about this idea of practical justice and what a commitment to practical justice means for how you formulate policy. So you can actually do things like select health conditions that don't exist necessarily in the West, but exist elsewhere, to focus on when it comes to vaccine development. So if you start to fund, research into things like Ebola, for example, that pushes people outside of, the West to other places where they start to set up labs, start to study these things. If you put enough money into it, maybe you drive investment into those areas as well. You need to think about recruiting and training and developing human resources outside of the West. One of the things I've tried to get people who work in my field to start thinking about is a mandatory requirement to recruit students and postdoctoral fellows from outside of the United States and Canada, and places where from places where they don't normally recruit. You want to think about the role of private funding in the global distribution of research resources, and because private funding is what it is, there's an expectation of private returns. So you might want to think of investing more public dollars in research. So there's the short answer to your question is think global. Unless you think global, you're not actually going to get there. And I think countries like the United States need to sort of have a deeper commitment to the idea of global than we do now. Unfortunately, that's not happening with COVID-19. What we've seen is a return to, me, as opposed to global.
All right, the next question is for Michelle about the role of politicians in contributing to the declining desire to be vaccinated. I'm guessing that's what people, the politicization of vaccination, and how do experts work to ensure, ensure that politicians support vaccination, but probably also that people understand the nature of this politicization.
Yeah, that's a important and I think tough question. I think we've really been challenged this past year with this issue of disinformation and how information is spread sometimes by our political leaders in terms of going against what is pretty well documented and well science, and so that's what we try to stand on. I guess there's a couple of things I'll say. I think as researchers, right, this novel coronavirus, it's challenging because in the beginning, people could only gather so much data. And so we were waiting for some of the data around COVID-19, and we're still waiting for vaccine efficacy and safety and stuff like that. And so, our hope is that obviously there will be the research to support the fact that vaccines work, So I think that that's one piece. I think the other piece that I say from a personal standpoint, because I always find, and I think probably politicians have a sense that stories are powerful, and they kind of can convey things that maybe sometimes the research can't when you're talking, especially like to the lay public, and it may not be so obvious. And what I usually share is my experience with taking care of patients with COVID-19 and how devastating that is, and kind of what would happen if nothing changed, and really I try to talk about personal stories and, and hope that that's compelling. So I think that is one piece. I don't know that politicians will always support our work, but I think as scientists, we try to go back to the science and then the patient standing in front of us. And I think it continues to be a battle. I'll also say that for me personally, I wasn't a huge social media person before this past year, but certainly tried to go where I think the people are and be on Instagram and do videos with different organizations and say, hey, I'm someone who has credentials and can speak about some of these topics, and try to battle some of that misinformation as well. In the places that people are actually going for their information. So I think, that's another piece, but I don't know if we'll always have their support, but we try to do the best that we can. So.
Yeah, if I could just underscore some of that. I mean, I think Ubaka, you made some points that when you told the story, stories are very compelling. So Michelle was just saying, but when you told the story of a person in the audience, who sort of came to you and said, should I get this vaccine? I think that it's going to be so important that we've got so much disinformation. There are going to have to be some more people serving as counter to, as sort of the counter forces to that, and whether it's through the social media sort of interviews and things, or even in the clinical setting. I mean, I think this is where that representation really matters, even among our healthcare professionals, so that some of these marginalized communities can look to their doctor and say, hey, is this a vaccine that you would take? And I can tell you that they are going to trust yes, I would take it if it's coming from someone who they share identities with a lot faster than if it's someone that they don't. And so I think all of that is going to be so important as far as the rolling out and sort of rolling out of vaccines, and also countering the type of information and disinformation that is out there. I think it goes beyond just the politicians. I think the politicians have fueled it for sure, but I think now it's in the fabric really, and we have to just in the broader fabric of really the world. And so we're going to have to consistently have a counter campaign against it.
Yeah, and I was just gonna.
Sorry.
No, go ahead, Ubaka.
Oh, okay. Sorry, just 2 quick points on this. It's a very fascinating topic. I'm part of a group in Canada that maybe I'm not even supposed to say this because it's still a secret group, but we're sort of working on a strategy, a national strategy for countering disinformation and misinformation. But two very quick points. The first is, I think one solution that needs to be explored is the depoliticization of decision-making around public health. Public health should not sit with politicians. There has to be a way of insulating it from political influence while bringing in political influence as a perspective. It shouldn't be the determining perspective. And I think that was what it was before, but we somehow lost, or well, the politicians somehow lost their marbles around this. And what we're seeing is so much political interference with that process. I think there needs to be a way to insulate that better. And then the second thing is that we have to, I think science and technology and public health and all these debates we're having around vaccines, they're really just proxies for broader polarization in our society. The fight is not really about vaccines and about science and technology. We're having, especially in the United States, much deeper fights about what it means to be humans. And sides have been taken, and people on both sides are going to keep having these fights. And I think this is just one of those expressions, or the proxy fight, really. And until we actually get back to the root of it, which is that we need some way to find commonalities that don't divide us so much, I don't think we're going to counter this effectively.
I was just going to add, piggybacking off of something Deidre said about you, or actually everyone's brought up this point about disinformation. I was thinking about in my home when we're even having discussion, it's like, how will you decide whether you're going to get this vaccine, right? And someone said, well, if Fauci says I should get it, I'll do it, And I started thinking to myself, like, maybe that works for some people, but like, who is the Fauci for the communities that I work with? And how do we get those people on board and understanding some of the implications of this vaccine and making sure they're comfortable? Because again, this goes back to this idea of what ended up working in 1918 for protecting those communities. It came back to that, having trusted people that they could believe the information. And as everybody has talked about, this rightful distrust, right? Like, how are we going to combat that too? There's some communities that are like, there's just so much different information coming all around me, but so who is my Fauci? And I kind of have been thinking about that and trying to think about how we engage those leaders in the community around this topic too. And I think that'll be equally important.
What have you come up with? Who are the equivalent? And I don't mean this just necessarily in the communities that you work with or in Black communities, but I think it's a really good question, because I think this idea comes up of who is everybody's Fauci, and I'm not sure that I've heard good answers to it.
Yeah, I mean, I think so. For some people, their religious leaders are really important to them, right? Like that ends up being a cornerstone, especially I think in the Black community, like church leadership. I also think, for me, I think about the pregnant population. I've been thinking a lot about how do we engage people that we don't necessarily always think about as our public health workforce. So I've been working with community-based doulas and trying to think about what their role is and how they can play a role. How there's other different kinds of, like, not even people, but conversations that are going around. There's like a new barbershop initiative that's a company now where they're trying to do COVID testing in barbershops. And we're thinking about, like, what are the conversations that go on when people, are just around around their friends, or they're, in a place that they feel safe, and how do we get those conversations going? So even thinking about barbers and like those kind of people that people feel like they can talk about their secrets, or beauticians, people who do hair, the places where, like, the Black community, for example, feels safe So those are just the ideas that I've been thinking about, but I am curious to know the solution.
In Alberta, where I live, our Fauci was, was because she no longer is, Dr. Dina Hinshaw, our Chief Medical Officer of Health. When the pandemic started, she turned into a kind of folk hero. People were, getting tattoos of her, making shirts with her face on it. And that was sort of the same for all of Canada. Most of the chief medical officers of health were women, and they showed sort of incredible leadership at the beginning of the pandemic in terms of explaining to people what was going on, making decisions, which obviously, were tough decisions at the beginning, and they built up a ton of trust. And then political interference started, right? And then the message got sort of mixed. There's lockdown, there's no lockdown. Why is there no lockdown, even though we have the same numbers as people who have had lockdowns have had? She stopped giving press releases, the government started giving press releases, and all that trust is gone now. So she's no longer a Fauci. And it tells us of the importance of trust, because her word was really something that people were really getting tattoos of her. I'm not making that up. But now it's swung the other direction. And she's the person who's going to have to sort of deliver the message about vaccines. And that's something that's a concern for sure.
It's fascinating. I like the idea of sort of I love the Fauci idea, and I like the idea of like these, that probably everyone has a Fauci, and they're probably not necessarily someone who's in a high, sort of position. So I think that's gonna have, that should be a whole campaign, find your Fauci, sort of, so that we can identify, who people are going to trust. I'm really hoping that there will be, celebrities, there'll be, sort of a broad swath of influential people that will publicly get vaccinated, on television, on YouTube, on Instagram, and allow people to see what happens to them in the days after, see that hopefully they're okay, and that sort of thing. I think that's going to have to happen. And obviously in every setting, every country, there may be different people that are revered in those settings and might be the best people to do that. But I think as far as the disseminating the good word about vaccinations, I think that those, the barbers, as Michelle was saying, other I think about peer educators, the type of people that we use in a number of clinical settings to educate patients, particularly who are educate and also support people who are going through either a tough diagnosis or some impactful clinical experience. Those types of people that we deploy, I think, will also be really important. I see in the chat teachers as well. Teachers are definitely trusted agents, and I'm sure for a lot of people that would be their Fauci. So yeah, I think it's going to take a lot of different people.
And if it's a celebrity on TV, it's a 2-part sequence. So that's good for ratings for the networks. All right, Shraddha has a hand up. Go ahead.
Hi, that was a great talk, by the way. And this is a question for any of the panelists. Speaking of trust, a lot of, I think all of you pointed out that certain populations, like Black communities and Indigenous folks, people of color, as well as certain countries globally, have obviously been disproportionately affected by H1N1 and COVID. But when it comes to receiving help and treatment, they're not the first to receive these treatment. But on the other hand, like historically, because there has been experiments done on Indigenous children in residential schools, this is the case in Canada, and just in the African continent in general, there's, I think, a certain distrust when it comes to novel treatment. For example, like when the COVID vaccine comes out, how do you think this should be approached or addressed? Do you have any ideas?
I'll jump in. So I think now that we have the disease here, and if we get a vaccine, the decision making around that will have to be different from the kinds of decisions we make in what I referred to before as peace times. So my response is a two-parter. I think in the context of what's going on right now, it really is a balance of, the risk of the disease, keep ravaging these communities, and this sort of panacea, however it might present. I think there's a ton of issues with the COVID-19 vaccine, a ton. It's the way it's being manufactured, the speed with which it's being manufactured, issues around who's in the clinical trials, how it's been developed. There's genuine issues that you're going to need to talk to people about. But we also have this disease. So I think for that, what you need to address that will be you do need to consider getting into these communities that are disproportionately affected. But you need to be very sort of upfront with them about what the balance of risk is. There needs to be clear communication, and there needs to be some provision made for how to deal with the health effects that result from vaccine outcomes. So maybe it's an opportunity to think about the kind of healthcare that we actually deliver to these communities and how we can improve that. Maybe it's an opportunity to think about social determinants of health and how we can improve that. But when all of this is over, if we're minded to think about this, and I think it was Dr. Cruz that talked about this before, we have to think about how we empower these communities to be the ones who generate the things that they use to manage this. Actually, in places in Africa, they've done really well with controlling this disease with just boots on the ground public health, contact tracing, isolating people, and that's what you want to do with technology around vaccines as well. You want to empower communities around the world to be able to actually design their own products, develop it, and distribute it. If obviously vaccines are being made in Africa, I don't think they're going to consider minus 80 degrees vaccines as good candidates. Maybe they'll start with dry vaccines. Maybe that'll be the thinking. But you need to get there by setting up a infrastructure and a context for them to develop these products themselves. And if we don't go there after this, it'll be, again, the same story of failure to sort of see that we need to think about establishing ways for these communities to empower themselves, for them to sort of help themselves and produce their own things with which to counter these public health threats and these global health threats we keep facing. So there's a short-term strategy and there's a long-term strategy, and they're very different, I think.
Yeah, I would echo that the short and long-term strategies are different. I think a lot about this idea of trust and what we're actually asking people to do. It's really not on, I guess, it's something that I think about a lot. Like, I think about the United States and the context of the United States and how it may feel like when we're talking to these communities, the United States is an addict who says they've changed, and they, for a long time, they've been addicted to power and maybe uplifting things that are aligned with white supremacy. And so it's not necessarily surprising that people would be reluctant to all of a sudden, now we're this great nation that really cares about these populations. And so, the long term is that they have to be shown over time. And I think the other piece, and whether this is short term and long term, but I think about what does it mean to show and not tell. I'm like wondering, where's the investment in the things that matter to this community outside of COVID-19? Because, Deidre, any of us could talk about how there's disparities in kidney transplants. There's disparities in maternal mortality. There's disparities in amputation of limbs. There's just disparities in access to basic things that people can't get. When I talk to communities, they tell me about the housing systems that they can't even think about their health because the process to get their houses fixed that are molding is so convoluted. And so what have we done to address all of those things before we're asking? Because this vaccine thing, to me, it's two ways, right? Of course, it individually protects people, but we're actually asking people potentially to do this for the greater good. But what have we done? So I think, you know, that's the bigger picture about what equity means, that it can't just be, you know, you should help us out in this moment, but we haven't done anything back. And that's part of kind of, I think, restorative justice and the things that we talk about. And then short term, I think, is something that Deidre also brought up. Short to middle term, I guess, is from a clinician standpoint, what it means to have diversity in terms of our workforce, and having being able to go, let's say, to your primary care provider. So like, again, the work that we've seen in influenza that a lot of people have done, especially with older adults who are going to their primary care providers, are going to ask you the question of whether or not you would do it. I mean, I can't tell you how many times I've leaned into a shared identity to say, like, listen, you know, I really think you need to get this colonoscopy. Black men have higher rates of colon cancer death. If you were my dad, this is what I would tell you to do. And how important that is to people. I think it really matters. I know Deidre just tweeted about this too, but you know, there's a physician at Emory University who wrote this Lancet piece about her experience being in a COVID-19 trial. And I was like, man, that is really gonna make her patients feel like, you know what, I thought this was so important that I actually went into a trial to be part of this, and that's why I believe in it. Not all of us can say that, obviously, but I think we're all gonna have to be able to answer the question and explain why, so.
Yeah, and just to underscore that same physician, Dr. Kimberly Manning, she's I think, third generation graduate of Tuskegee University. So the article is really framed around, you know, that legacy of that institution, and the fact that she, you know, went forward with that. You know, I think so much work to be done in terms of building trust, and you know, I really think that in the short term, we're just not going to be able to go to these communities and say, hey, let me have you take this vaccine, unless there is that trusting relationship. So that really argues strongly that whomever is going and offering the vaccine to them needs to be someone that they have a trusting relationship with. This is not going to be a time where we're going to be able to even establish these sort of new kind of relationships and start to do some of the work that we need to do to restore trust. So I think it really is going to be a time to kind of galvanize those trusted agents and have them be the ones to offer the vaccines to these communities that are certainly going to need it.
This one's for Michelle and for Deidre. Ubaka's talked a little bit about the particular challenges of the Pfizer vaccine. You know, it's a minus 80-degree cold chain. And I'm curious if either of you guys have thought about that, because, you know, I mean, that's tough for a lot of places in the United States too. And the very specific restrictions on like when it needs to be administered there just seem to be so many obstacles. And then on top of that, if these are only going to be at, you know, Johns Hopkins University Hospital, I'm just curious how you guys are thinking through the specifics of this vaccine, and whether you know, and how much you've thought about that, and if you have any additional thoughts.
Do you want to go first? Yeah. She'll be giving more of them than me, I think.
I think these are really hard questions. I think that we've all thought about it, even with that, in that model that I talked about, when people think about their perceived barriers, like if they look at a vaccine and say, yeah, maybe I think I'm at risk for this disease. Maybe I think it could seriously hurt me. Maybe I think I could potentially benefit from a vaccine. And then I look and say, it's not accessible to me, then I won't, you know, I'm not even going to necessarily try, you know. So that, I think that's going to be really hard work. I don't know that I know the answer. I think in most of these things, I talked about this idea of anchor institutions, and like, of course, Hopkins, like for example, in the Baltimore community, even though it's Hopkins in terms of, you're saying, you know, potentially research reputation, the community that it serves, like Johns Hopkins Hospital, is, you know, a historically marginalized community that'll have a lot of these challenges. And so for all of the institutions, when we say they have a responsibility to the communities they serve to figure out how we're going to make this equitable. And I know, I mean, that seems easy, right? But when we are truly talking about anchor institutions, we're like talking about putting your money where your mouth is, not just, yes, we're here benefiting from the research, but that we have a responsibility to really give back. And that's true across the country, because what makes something an anchor institution is like they contribute potentially to the economy. They employ people in the cities that they, you know, that they sit in. They're vested in these communities in different ways, and the communities have given to them. And so what are they going to do to give back? I mean, that's one of the things that I think of. And then there's always high policy levers, you hope, but those things are challenging too. So.
Yeah, and I'm hopeful, you know, with like those resources. Yes, I am one that even has some research samples in a minus 80-degree freezer, so I am familiar with with these freezers. But I also know that they are hard to come by. But from what we're learning, it sounds like there are a number of pharmacies that are already sort of setting up. Walgreens, I think, even has. I think I called to refill a prescription the other day, and Walgreens already has an advertisement saying we will be a distribution site when a COVID-19 vaccine is available. And so hopefully that will be the case. I'm also thinking about and cognizant of, you know, rural health disparities, and that there are so many rural communities that I also think are going to be at a tremendous disadvantage and are probably going to need some special attention as far as thinking about how they're going to access the vaccines. But yeah, it's you know, that's just, I mean, that's just a basic thing. So how it's the freezer, it's the storage, it is the quickly getting the vaccine from that freezer to the person, into the person's arm, you know, as well. All of those are going to be logistical challenges for sure.
This is drawing on something Michelle just said as well. Do you think that there's particular energy in places like Johns Hopkins to do the equity work and to do the outreach, like after the Black Lives Matter protests? I know that a lot of, you know, predominantly or historically white institutions have, you know, released a lot of statements. And I'm curious if it feels like there's, whether it's authentic or not, or whether it's going to be realized or not, I'm curious to whether it feels like there are people who really want to take advantage of this because of the context of the protests and everything that's been going on.
Yeah, I would actually, I'm sure that across all institutions, like you kind of alluded to, that there's this, you know, there's this concern for performative allyship, which I think, you know, is valid. One of the things that I also say is like, we have to use the momentum that we have in this moment. I mean, I could say that at Johns Hopkins today, the Center for Health Equity celebrated their 10-year anniversary. And it's interesting, one of the things I was reflecting on that kind of celebration is, this has been a 10 years, and probably way longer, of building trust in the communities and having these partnerships and relationships. It didn't just happen overnight. I think that there is an opportunity for the centers that have been doing that work to lead the efforts, you know, and I think too that like the funding mechanisms from, you know, the higher up, the funding and the priorities also shift to kind of make sure that this momentum continues. I think the other thing I think about with COVID-19 is, as we've talked about, is how much these chronic diseases, like they play such a role. That's one thing. And then the long haulers of COVID-19, that's the other thing, as we deal with kind of the implications for further on down the road. It's going to require continued investment in these issues. And one of the things with the 1918 influenza virus, and obviously what we're seeing today, is that there were waves of the disease, and we've had to kind of be responsive, to what's in front of us. And I think we'll have to continue to do that in different ways. And so I don't know the answer. I think here it does feel hopeful because the center of health equity is respected in that way, not only in the community, but in the institution. And honestly, people are just like, this is so, like, for some institutions, I was like, oh my gosh, this information is like, our eyes are so open. A lot of us have been doing this work is like, yeah, we've been seeing these issues for a long time, but now that everyone's eyes are turned towards this way, great, don't worry, the capacity is there, to move that work forward. But yeah.
Yeah, and I think that's definitely part of my question is in some ways, how can you each take advantage of one another, and hopefully, long-term mobilize it towards something that's really transformative as well for both, for both the university and for all of the communities involved.
Yeah, and I'll just add to that. I will say there was a moment early in, I would say, 3 or 4 months ago that it was interesting and in some ways almost annoying, the amount of like new attention to these issues that have been here forever, really, it feels, and so many of us have been, working on trying to address these issues. But I have reframed my annoyance and have now really been trying to think through, and I think a lot of people have, like how to kind of capitalize on this moment where there is attention and necessary attention, given that we're all affected by this. I mean, I think on the one hand, we had been reliant upon kind of altruism that we hope that people will care about these marginalized communities, but now we actually realize that we truly are all in this together and all affected by one another. And so I think there is a real opportunity. The recent high profile acts of racism, in addition to how that layered on top of COVID has led many institutions to then think about health equity work. There's also been a lot more work in the healthcare sector around healthcare workforce diversity as well. And so I think there is an opportunity as well for for us to make some advances there. I get a little nervous when I hear of efforts that just seem very superficial and are not, particularly on the health equity side, that are not really seeking to engage with communities in meaningful ways and really partner with them, to do the sort of work. That's when I get a little nervous, but I am hopeful that we'll see real action.
If I can just quickly offer just some insight on this, because I completely agree with all that's been said, but I do think we also have to be careful about not sort of these institutions not using this moment to sort of develop a savior complex that is actually misplaced. That actually concerns me a lot, because I think the COVID-19 vaccine is not a benefit to Black people and to racialized communities. It's a burden. It's a burden because it wasn't tested in these communities. When it's provided to them, they are being trialed. That's the truth of the matter. They are trial participants in something that's being presented as a cure. There needs to be a lot of thinking given to the same things you do for clinical trial participants needs to be available to them. Healthcare for any effects that have not been studied, making sure that they're taken care of if something happens to them and have to get off work. There's just a whole lot of thinking that is now being sort of swept up in this moment of sort of real anxiety about the disproportionate impact on them and the need to get it to them. So I don't think the allocation decisions are actually that easy. This is, I think, a burden to Black people, and it needs to be thought of as that. And the same kind of measures that are available to clinical trial participants should be made available for these communities. They're really just trial participants, in my view.
All right, so we're just about out of time. Any last thoughts from the panelists or a last question from the audience? The one thing that I'll add is certainly with a lot of this racial equity work that we're trying to engage with, or scholars are trying to engage with, is moving from where the energy around race has been in the United States to moving to global concerns. So we are continuing the panels in December and ongoing, and some of those will be dealing with international concerns. With access in Africa is going to come up in December. We're going to have some panel probably on issues in South Asia in January, as well as continuing to think through what's going on in the United States as this vaccine unfolds, however it's going to unfold. So once again, thank you to the panelists. Thank you for everyone for attending. And if you have any questions, you know how to reach us.
Thank you.
Thanks, everyone.
Yeah. Thanks for having us.
Thanks. Take care.